Welcome to this talk. My name is Gabriel Mistelbauer and I'm with Stanford University School of Medicine. I'm happy to present our work on transdisciplinary visualization of aortic dissections. Before we talk about aortic dissections, let us describe the anatomy of a healthy blood vessel with a single blood flow channel that is referred to as true lumen. If blood enters the medial layer of the aortic vessel wall through the primary intimal tear, the single flow channel, true lumen, is divided into two channels, a true lumen and a false lumen. This leads to a dissected aorta with both channels separated by a thin elastic membrane, the dissection flap. The cross-section of aortic dissection could look like this. On the right, we see a computed tomography angiography dataset that shows the true lumen mask in red and the false lumen mask in blue. A comprehensive perspective and understanding of the pathophysiology of aortic dissection requires a wealth of data that is analyzed and visualized in a meaningful way. To accomplish this, we start with the segmentation or labeling of data such as the true lumen and false lumen. Segmentation is also used to extract morphological features and to localize landmarks. It is the basis for subsequent analysis, simulation and visualization. Prediction models are often based on morphological features and rely on the accurate and reproducible extraction. These models aim to predict late adverse events and patient-specific outcomes. Computational fluid dynamic simulations can be used to study the impact of hemodynamic features on disease progression. Such features relate to late adverse events, individual patient outcomes, and informed treatment decisions. We can also investigate the effects of different flap stiffness on the hemodynamics. The large amount of extracted, generated, and simulated data needs to be visualized in a meaningful way. This requires custom means, especially if the intention is to make this data accessible to clinical and patient care. This transdisciplinary process towards a comprehensive understanding of aortic dissection is often not a straightforward process, but an iterative one. Studying aortic dissection requires labeled data. For example, visualizations are often based on segmented data, simulations directly build upon segmentations, and risk prediction models could be streamlined with automated segmentation and feature extraction. Segmentation is therefore the foundation for various applications. For that reason, we initially segmented the true and false lumen. Since manually segmenting true and false lumen is very time-consuming, we developed a machine learning approach. First, the aorta is localized in the input CTA dataset, then we extract its center line and create a reformatted volume along the center line as shown by the gray cross-sections. True and false lumen are then segmented with another neural network in the reformatted volume. The true lumen is shown in blue and the false lumen is shown in red. Finally, the segmentation mask is transformed back into the original dataset. Once we had labeled the true and false lumen, we also segmented the false lumen thrombosis. We had two aims. First, again segmenting true and false lumen, and second, segmenting false lumen thrombosis. For that reason, we developed three models. The first model is a single-step multitask model to segment the true lumen, false lumen, and false lumen thrombosis in the original dataset. The second model is a sequential model that localizes the aorta, creates a reformatted volume along its center line, segments true lumen, false lumen, and false lumen thrombosis, and transforms the results back. The third model is a single-step, single-task model that segments false lumen thrombosis directly from the manually segmented false lumen mask. So far, we labeled the true lumen, false lumen, and false lumen thrombosis if existing. Ideally, data prior to the development of the dissection should also be considered. However, such data is only available in rare circumstances, but it could provide valuable insight when or where a dissection might occur. For that reason, we aimed at reconstructing the aorta before the dissection formation. We considered the false lumen as an image artifact and apply a freeform mask to exclude it from the dataset. We trained a two-stage 3D generative adversarial network that hallucinates edges of this mask volume and performs edge-guided inpainting. Here we see in A the original dissection, in B the true and false lumen labels. The false lumen is masked for removal in C, and the virtual pre-dissection result is shown in D. The diameter of the non-dissected aorta is smaller than the original dissected input. After having a virtual aorta prior to dissection formation, we located important landmarks along the aorta. The aorta is divided into 5 segments and 8 to 11 landmarks. In this work, our goal was to localize the aortic annulus, the first landmark as shown in orange in the right image. This landmark is important for aortic valve repair, measurements, and center lines. We used deep reinforcement learning to train 5 agents with different windowing functions and dropout rates. We could achieve a result within an error margin of 3 mm compared to the ground truth. Once we segmented the true lumen, false lumen thrombosis and located the aortic annulus, we started to analyze the extracted wealth of data. We initially developed a risk prediction model by analyzing several imaging features and determining the association with late adverse events to stratify patients into low, medium, and high risk. We identified the following risk predictors: connective tissue disease, false lumen circumferential extent, maximum aortic diameter, false lumen outflow, and number of intercostal arteries. On the right side is the interface of our risk predictor. The results of our study was a patient-specific risk model to predict the event-free survival for the upcoming 1, 2, and 5 years, as shown in the Kaplan-Meier diagram on the right. After the risk prediction model, we assessed the measurement variability, specifically the reproducibility of aortic measurements. We used the imaging predictors from the previous study, as shown in the right images: maximum aortic diameter, false lumen circumferential angle, false lumen outflow, and number of intercostal arteries. We designed 3 experiments, including 4 observers. The first experiment consists of using post-processing software without a dedicated workflow. The second experiment uses a standardized workflow. Before conducting the third experiment, observers were trained with consensus reading and a standardized workflow. The outcome showed that using a standardized workflow reduces the inter-observer variability of aortic measurements. After assessing the inter-observer variability of aortic measurements, our next project was to automatically derive the cross-sectional planes for these measurements. The surveillance for aortic dissections over time requires diameter measurements, usually performed in cross-sectional planes at predefined landmarks along the aorta, as shown on the right. These planes are manually placed and aligned by the radiology technologists. We aimed at automatically defining these planes using a convolutional neural network. The outcome showed that the trained model has an average error like an experienced technologist. So far, we talked about segmentation and analysis of aortic dissection. The next topic concerns computer simulations to obtain patient-specific hemodynamic parameters. Hemodynamics can assist risk prediction in type B aortic dissection. However, 4D-flow MRI is not routinely available. Therefore, we are interested in simulations to obtain information on wall shear stress, streamlines, and pressures. On the right, we see the dissection flap moving during the cardiac cycle, with its area extending during systole. In this animation, we see the flowchat from the true lumen to the false lumen in systole and a small flowchat from the false lumen back into the true lumen during diastole. These flowchats indicate pressure differences between true and false lumen. In this topic, we devoted ourselves to the question of whether hemodynamic parameters can predict the risk of late complications. For that reason, we use computational fluid dynamic simulations with fluid structure interaction. Our workflow relies on high-quality segmentations of patient-specific geometry and, when available, 4D-flow data. From this geometric data, we built the aortic mesh with the structural domain vessel wall and flap shown in white and the fluid domain shown in turquoise. We then apply boundary conditions, define our simulation setup, and run the FSI simulations on high-performance computers. The results can then be post-processed, analyzed, and visualized. We were then able to compare the FSI simulation results with the 4D-flow data of the same patient. We also investigated the effect of intimal flap stiffness on deformation and pressure differences between true and false lumen. After segmentation, analysis, and simulation, we proceed to visualization to communicate our findings. Initially, we displayed the aortic diameter measurements in the aortic surveillance program in the form of a conventional 2D plot. The x-axis depicts the aortic landmarks and the y-axis the major diameter. The 3D shape of the aorta is shown around the x-axis. Here we see 12 examinations over 5 years and 2 months. These examinations are overplotted. Examinations before interventions and the current aortic state are colored. Following the diameter plot, we developed aortic dissection maps. It is an extensible visualization that is composed of 4 plots: the diameter plot, the branching plot, the intervention plot, and the event plot. Aortic dissection maps enable risk assessment and different levels of detail. They depict multiple aortic features and include a risk calculator. After these 2D visualizations, we introduced a 2.5D visualization named pop-up plots. Instead of a Cartesian coordinate system, we use an ellipsoidal one. Time is explored by interaction, rotation. Analogously to pop-up greeting cards, exploring time pulls the plot out of the image plane, as illustrated on the right. This enables seamless transitions between space and time. The frontal view resembles the conventional diameter plot. The top view shows the examination dates where time is arranged as rings. The side view depicts the temporal development of the aortic diameter. From a 2.5D visualization, we now move to a 3D visualization by implicitly modeling aortic dissections. The basis is, again, segmentation, followed by contour extraction, and finally, rendering. This case presents a Sandfort type B aortic dissection extending from the descending thoracic aorta to the abdominal aorta. The current image shows a 2 mm true lumen wall thickness and a 1 mm wall thickness for the false lumen. We use 10 harmonics for the surface reconstruction. If you plot the true lumen and false lumen separately, you can see that the true lumen is quite narrow and the false lumen is quite enlarged. This image shows the branches in the aortic arch from the inside of the aorta. Here we can see the true lumen and false lumen branches are properly connected to the corresponding lumens in the parent branch. After being able to create 3D surface models of aortic dissections, we investigated different shading styles. The surfaces of the dissection flap, the true and false lumen, and the outer vessel wall are first rendered using Blindfong shading. We then use RNIR and cooked orange shading, screen space ambient occlusion, and order-independent transparency to show all surfaces together. This concludes our transdisciplinary work over the past 7 years. Aortic dissection is a complex disease with a high degree of variability. Therefore, a holistic assessment requires transdisciplinary research. Implementing such a research venture requires time and a team of dedicated experts of various disciplines, such as computer vision, machine learning, data science, biomechanics, and computer graphics. These experts are then coordinated by radiology, and visualization acts as a unifying discipline for communication within the research team, to professionals, and to patients. Finally, I want to thank my colleagues of our transdisciplinary team, as well as other experts. Thank you for watching.